I said to you earlier that none of this matters if it doesn't work. None of it matters if I just get up here and say, you know what? This is really cool. This is so cool that I use it every day and it's fantastic. But I don't have any proof that it works. All I have proof of is that it's cool. Well, that's not good enough. You know, you can't work on people and experiment. You can't use products that don't work. You can't use products that aren't proven. You can't use products that don't have any scientific backing. You can't use products that don't have any university studies or independently studied aspect to them, in my opinion. I personally or professionally cannot use something like this in my office if I don't see any scientific evidence. So there's a gentleman up in the right corner. He was the head of periodontics at LSU. Now he's the head of periodontics at the University of Colorado in Boulder, the Department of Periodontics at the University of Colorado in Boulder. And he has done a study, a human study, and his name is Ray Yugna. Took 6 patients, 2 teeth per patient. I didn't bother to tell you what LANAP stood for, so I'll tell you now. It's Laser-Assisted New Attachment Procedure. So all 6 of the teeth that received treatment with the laser, with the ND-YAG laser, who received the LANAP protocol, the patented protocol, had what is called new attachment, which is an absence of the long junctional epithelium. Now, let me say that new attachment is the absolute, positively gold standard of periodontics. There is nothing I can do without the goal being that I get new attachment. Here's the problem. There's no technique that will give you new attachment because everything heals with a long junctional epithelium. Not just for me, for everyone, because that's just biology. So new attachment is something that we strive for in every technique that we utilize, but it's very, very difficult to achieve, and in fact, maybe not achievable, except this shows new attachment. So that makes it really, really special. So on the right are the control teeth with scaling and root planing. And on the left are the LANAP-treated teeth with bone. Nothing proves the point better than histology. Because if you don't have human histology and you just say, well, it seems to me that this is the best we can do, or it seems to me that this is what you should be doing, that doesn't mean anything. This is what has meaning. And this right there is new attachment. That is new cementum, new periodontal ligament. That's new attachment, as opposed to scaling and root planing histology. All this is inflamed tissue with no attachment. This will ultimately heal with a long junctional epithelium. That's fine, because that's the best we can do. That's the biology. But what the laser did was it changed things. It made everything stick. So it did what nothing else really can do. Now, there have been other things that people have tried to show new attachment. You know, iliac crest bone, different freeze-dried bone products. You know, there are people out there who do this kind of work, and they have histology like this, and they'll say, oh, my technique works. Well, it may work. It works for them. That doesn't mean it'll work for me. The issue is, can this work for just about maybe everyone who uses this laser? Because if it just works for a couple of people, it really doesn't matter. And that's the whole problem in dentistry. You've got to have something that works for everyone. So here's what the ND-YAG laser does. Removes epithelium and leaves the connective tissue reedy pegs intact. It kills periopathogens. It alters the composition of calculus. It neutralizes endotoxins in cementum. It has a biostimulation factor. And most importantly, as I'll show you, it establishes a stable fibrin clot. That's kind of gross. Those are poached eggs. And the idea behind me showing you this is that this is what the laser does to the blood in the PDL. It is a poaching action which makes a fibrin clot. And this is what makes a seal. Okay? So what we are doing is, if we can create a clot and we can localize the PDL and we can localize the cells in the PDL, let's call them progenitor cells, which they really are, and we can make them grow, that's how we get our new attachment. So LANAP equals new attachment, cementum, periodontal ligament, and bone, which is extremely unique in periodontal therapy. Very briefly, we probe, we make a pass with the laser. Occlusal equilibration, very important. We don't want smacking on the teeth because it affects the PDL. That's where all the healing comes from. So we do a lot of occlusal equilibration just to keep things calm with the PDL. This is the protocol. This is what gives it the outcome. I can't deviate from this. If I'm treating someone, like tomorrow morning, I'm not going to wake up tonight and think, well, you know what, I think I know a better way. I can't do that. This is the protocol. It's the protocol tomorrow morning and every morning that I turn that machine on in my office. If you don't deviate, the thing will work. So I think maybe some of you are familiar with the CRA newsletter. This is Gordon Christensen's group. They test products in dentistry, and they theoretically have no axe to grind. They're not paid by the companies, and they evaluate products in dentistry. And they evaluated this laser. The best part of this is, I think, they asked 81 laser owners, this laser, 81, if they would buy this thing again. And all 81 said yes. It's actually very interesting. I don't want to go through this. The writing's too small. But it's really very interesting. The overall satisfaction, 9.7 out of 10. Patients have accepted laser therapy, 82 to nothing. So I can give you copies of this if you'd like to see this further. But it's interesting because this is an unbiased evaluation of the product. So what are the advantages to your patient? Single appointment surgery. Let me clarify something, because someone mentioned this before we started. There is no initial preparation with this technique. There is no scaling and root planing by the hygienist when this technique is used. It's all done at the time the procedure is done. One procedure, not multiple appointments, not the patient coming back time after time. One appointment. No incisions, therefore no sutures. I won't say no swelling. Let's say minimal swelling. The swelling they get from the anesthetic, really. It's not really from the procedure, it's from the anesthetic. This is big. No time off. You know, people, I assume that most of you heard this in your practices. People are very conscious of how much time they are taking off from work these days, and rightfully so. There is no downtime with this. People are going back, they'll go back to work, they'll play golf, they'll work in the yard, they'll do whatever they want. If it's not that day, it's the next day. Let's say it's 2 days. it's still different from conventional treatment in that regard. Under the best of circumstances, there's a lot of residual soreness. I've been doing this for 25 years. I've heard it all. And I think I'm good at what I do. But I'm not above telling you, you know, it's not that comfortable for every single person that walks through the door. But this is, it has been, I will say. So not taking time off, not losing time off to recover is huge, particularly at the moment. No root hypersensitivity. How many patients do you see for supportive periodontal therapy? You can't even go near them. You can't turn your Cavitron on. They won't let you. It hurts. And that's where Procter & Gamble and Colgate come in a little bit with some of their products. But, you know, I mean, it's just a reality. I'm not telling you something that I'm making up. I think all of you know this. Reduced chance of cervical caries. Let me tell you the reason. Because there's no recession. I'm not making an incision. I'm not removing really any gingiva to get flap access. There's no recession. So there's less chance of cervical decay, class 5 decay. That's a big thing. Patients get older, as you guys know. I mean, those lesions they're tough to do sometimes. So with this laser, you won't get the same recession as you'll get with conventional osteosurgery. Now, the papilla in the posterior will shrink. If there's bone loss, you'll get a little shrinkage because of the reduction of inflammation. But you won't get the look that you get with apically positioned flaps, which is a lot of cementum and a lot of tooth length. You don't get that at all. And, again, very big, I think, you can treat patients with aspirin, Plavix, Coumadin. It doesn't matter. You may want to speak to the physician and tell them, but there's no particular difficulty in doing that. Everyone can be treated. They're taking cyclosporin. If they had a kidney transplant, anything, it's fine. Not a problem. And no damage to the root surface or pulps. Advantages to the hygienist. Happy patients. What a novel idea. An ability to scale roots that are not hypersensitive and improve patient compliance with plaque control. You know, if patients are in pain, they don't want to do what you ask them because it hurts. They're not going to follow what you say. But with this, they might. You have a fighting chance. And then there are advantages to the general dentist. Now, there's a handout with all of this on there. The advantages to everybody is on a handout. So we don't have to go through this. You guys get your handout? Okay. Those are the advantages. Again, it's important to say preservation and regeneration of bone around individual teeth. That's just really huge, because what you do when you do osteosurgery is very often, well, what you are doing is you're